Well, good morning, everyone. My name is Deji Adegunsoye. I'm a pulmonologist at the University of Chicago with a special interest in interstitial lung diseases. I'm also joined today by Andrew Gangemi, a physician member of our ATS General Club leadership, who is an outstanding pulmonologist from Temple University in Pennsylvania. Welcome, Andrew. The topic for today is microscopic small airway abnormalities identified in early idiopathic pulmonary fibrosis in vivo using endobronchial optical coherence tomography. It's based on the Blue Journal, the AJRCCM article, and will be presented by Sarita Berge, a master's student at the Division of Pulmonary and Critical Care Medicine, a Mass Gen hospital at Boston here in the United States. So she's also the first author of this article. Welcome, Sarita. So I want to first begin by thanking Samantha Carpin, the ATS Assembly Programs Coordinator, for helping to facilitate this Journal Club webinar. It's a ton of work. And we also appreciate other members of the Clinical Problems Assembly who helped to put this whole thing through. The way we're going to proceed today is that we'll begin with a short presentation of the paper by Sarita, and then we'll take questions from the panelists as well as the audience. So feel free to type in your questions in the chat. I will monitor those and answer them as we go along. I'll also now introduce the expert panel for the webinar, and it's my unique pleasure to say that we are very fortunate to be joined today by an exceptionally talented panel for what promises to be a very rich discussion, so stay tuned. First, I'll welcome Dr. Lida Hariri, a pathologist from the Department of Pathology at Mass Gen Hospital in Boston. It's a pleasure to have her on board. She is also the senior author of this article, and she's published several landmark papers on the use of OCT in fibrotic ILDs. Welcome, Lida. We also have Professor Kerry Johansen, an outstanding ILD pulmonologist from the University of Calgary in Canada, all the way across the northern border. She's here with us today as well. Welcome, Kerry. And then joining us today is Dr. Barry Shear, a pulmonologist from the Harvard Medical School at Boston as well, with special interest in ILD. And he's also a co-author, a senior author of the study as well. Welcome, Barry. And to add exciting perspectives, we are also very fortunate to be joined by Drs. Anna Podolangzuk and Dr. Kristen Berger, who both wrote an exciting editorial on this paper. Dr. Podolangzuk is an internationally renowned ILD expert, and she's also a physician scientist, specializing in the care of patients with pulmonary fibrosis. And Dr. Kristen Berger is a pulmonologist with interests in prognostication of ILD, and both of them practice at Cornell University in New York, both here in the US as well. Welcome to you both. So without any further ado, we'll now listen to Ms. Berge as she takes us through this exciting work. So Sarita, over to you.
Thank you so much, Deji, for that wonderful introduction. Let me just share my screen. Okay. Can everyone see that okay? Okay, awesome. All right. So yeah, I'm Sarita Baragai. I'm a master's student from Mass General Hospital, and today I'll be discussing our recent publication on microscopic small airway abnormalities in early IPF identified using endobronchial optical coherence tomography. I'd also like to thank the Clinical Problems Assembly for hosting this journal club and for the opportunity to present our work here. I'm really, really excited to be able to talk about this project and to discuss with all the amazing panelists who I'd also like to thank for being here. This study did involve quite the multidisciplinary team, and I'm so grateful to have had the opportunity to work with all the co-authors. I'd especially like to thank Dr. Shankar Nandi and senior author Dr. Lida Hariri for their contributions and the excellent guidance they provided me through this project. So what is idiopathic pulmonary fibrosis? We know IPF is a chronic progressive fibrosing interstitial lung disease, and it's generally characterized by the usual interstitial pneumonia pattern on histology and radiology. When we think of the pathogenesis of IPF, it is widely considered to be a disease that almost exclusively destroys the alveolar parenchyma in the subpleural lung while sparing the small airways. So what evidence do we have that this is predominantly a subpleural disease? Well, patients with IPF generally have pulmonary function tests with high airflow rates and low lung volumes with restrictive defects. So we've kind of assumed that the small airways are not involved in the disease process, but we don't really have any other evidence to support that. So are we really sure that there's no small airway involvement in IPF? And the reason we ask this question is because small airways are notoriously elusive to current diagnostic methods and are therefore referred to as the quiet zone. These are airways that are less than 2 millimeters in diameter. And so that size makes it difficult to detect abnormalities, especially in the early disease stages. PFTs and HRCT are both critical right now for the diagnosis and monitoring of IPF. And PFTs in particular are great at assessing obstructive lung diseases, but when those diseases are in the early stages of development and involve more subtle small airway changes, it is difficult to detect. And then with HRCT, we would see macroscopic signs that might indicate small airway abnormalities, but because of the resolution limitations, it wouldn't be able to resolve the more subtle pathophysiologic features until the disease is more advanced. So it would be difficult to see any microscopic small airway disease features. So the reason we wanted to look at the small airways in IPF in the first place is because there have been some really interesting recent micro-CT studies from Verleden and colleagues in Lancet and Ikezo and colleagues in the Blue Journal. These have shown some really fascinating evidence of small airway involvement in UIP of IPF in explanted end-stage lungs, both in areas of established disease as well as in less affected areas. So here I've pulled a figure from the 2020 Verleden study in the Lancet, and you can see they compared these small airway metrics across 3 groups. They had a control, minimal fibrosis, and established fibrosis, where the minimal and established groups are airways that are less affected or more affected from IPF end-stage explants. In terms of airway lumen and wall measurements, they found that both IPF groups were significantly more distorted when compared with the controls. And then as far as terminal bronchial number, they also showed that in IPF explants, both in areas of minimal fibrosis and established fibrosis, that there was a significantly reduced number of bronchioles as compared with controls. And so these findings were really intriguing because even in the areas that lacked the established fibrosis, even those areas were evidently undergoing significant small airway architectural change and bronchial loss as compared with the controls. This is a figure from the 2021 study in the Blue Journal from Ikezo and colleagues. They did have some differing methodology from the Verleden study, but ultimately their results strongly supported that study, again, showing a reduced number of bronchioles as well as significant airway lumen distortion in the IPF explants as compared with controls. So the data from these studies was really exciting and started to lead to the question of whether we would see similar small airway abnormalities in the early stages of IPF as well. Micro-CT, while it is an excellent modality that allows for microscopic imaging, it is limited to ex vivo tissue. And because of the sparsity of early stage IPF explants, these studies were limited to small airway evaluation in end stage IPF lungs. These studies also didn't really have the ability to control for smoking history, and the healthy control lungs that they used were almost exclusively from non-smokers. So there were still some remaining questions about whether these findings are due to smoking-related small airways disease or due to COPD or emphysema rather than to IPF pathogenesis itself. So based on all of this evidence, we are hypothesizing that there is small airway involvement in early IPF. And in order to test this hypothesis, we would need a microscopic imaging method that allows us to evaluate small airway parameters in patients with early IPF in vivo. So we used endobronchial optical coherence tomography to test this hypothesis. It's essentially a high-resolution bronchoscope compatible imaging modality. The flexible OCT catheter can be advanced through the bronchoscope working channel and extended until resistance is met in the subpleural lung. And it can capture these images with less than 10 micron resolution, which is 200 times higher than that of HRCT. It can also produce these volumetric data sets, like you can see here, and can image about 8 to 10 centimeters of airway in less than a minute. So we can evaluate tissue 100 times larger than what we would get with a surgical lung biopsy. And we can also image multiple distinct anatomic sites in the bilateral lungs to capture disease heterogeneity. So in a study published recently by Drs. Frank Nandi and Rebecca Raffaelli in the Blue Journal a few years ago, we actually validated EBOCT to have strong accuracy in detecting microscopic early UIP. Patients were recruited who had low confidence ILD diagnoses and were therefore undergoing clinically indicated surgical lung biopsy. And we wanted to assess the sensitivity and specificity of EBOCT for detection of UIP of IPF, as well as the diagnostic agreement of EBOCT with the ILD pattern diagnosed on histology. And EBOCT ended up being able to detect early UIP of IPF with 100% sensitivity and specificity. And it was also able to diagnose other specific ILD patterns with high accuracy and strong agreement with corresponding histology. So here's an example of what UIP of IPF looks like on EBOCT. We have a normal lung on the left, which shows patent alveoli and thin lattice-like alveolar walls. On the right, we have a UIP of IPF EBOCT image, which shows the alveoli being destroyed by dense destructive fibrosis. You can also see these embedded honeycomb cysts. And we see the same thing on the corresponding histology. And the airway on the right here was classified as UIP of IPF, following the same criteria used for the histology diagnosis. As part of that study, we had also evaluated other major ILD patterns and validated OCT criteria for their diagnosis, including NSIP and airway-centered fibrosis. And we can see the features that characterize those patterns on the EBOCT volumes and the cross-sections. Like for the NSIP, you can see the interstitial fibrosis here and in the cross-sections. And for the airway-centered fibrosis, you can see fibrosis here in the more proximal end of the airway. And then distally, there is preserved lung parenchyma with some hyperinflation. You can also see some traction bronchiectasis in the cross-section here in the bronchiole branching off of this main airway lumen. So in this study that we did, EBOCT was performed as previously described in the 12 subjects from the EBOCT diagnostic study cohort that were diagnosed with UIP of IPF. And these diagnoses were confirmed by consensus between 2 independent thoracic pathologists and 2 independent pulmonologists. And then 5 non-ILD control subjects were prospectively recruited for this study to undergo EBOCT imaging. And they were matched to the IPF cohort for age, sex, smoking history, height, and body mass index. These subjects also had no clinical or radiologic suspicion of ILD, and they were undergoing clinical bronchoscopy for distal lung nodule resection. And so our outcomes for this study were to find the bronchiole count, the number of bronchioles per centimeter cubed of airway, and then also to measure these airway lumen stereology metrics, which included area, perimeter, Barrett diameter, roundness, circularity, and surface irregularity. So for each subject in the IPF cohort, EBOCT sites were chosen based on areas of abnormality on HRCT, and that included the upper, middle, and lower lobes just to capture disease heterogeneity. And for the subjects in the non-ILD control cohort, just to mirror the site selection in the IPF cohort, EBOCT imaging sites were also chosen in the upper, middle, and lower lobes in the bilateral lungs. We evaluated all of the cross-sectional images from all imaging sites in the IPF and control subjects, and the IPF imaging sites were further categorized then as IPF affected or IPF less affected. The EBOCT imaging sites that met all the criteria for microscopic UIP were classified as IPF affected sites. And then the sites that had some but not all features of UIP were classified as IPF less affected sites. The criteria for the UIP guidelines, or the criteria for UIP includes dense destructive fibrosis and honeycombing, and this criteria is the same as what was used in our prior OCT diagnostic study, and it mirrors the criteria in the ATS guidelines for histopathologic UIP diagnosis. So let's visualize some of those features. On top here, you can see an EBOCT volumetric reconstruction of an IPF-affected airway. You can see, again, it has this dense destructive fibrosis with embedded honeycomb cysts. This meets all of the criteria for microscopic UIP, so it was classified as an IPF-affected site. To contrast here, we have a volumetric reconstruction from an IPF less affected site. It lacks any honeycombing, and there is some patchy fibrosis, but it's mostly interstitial, sparing the alveoli. But there's no honeycombing, and we don't really see any destructive fibrosis. So it doesn't meet the criteria for microscopic UIP, but it was from an IPF patient. And this kind of heterogeneity within patients is pretty typical of IPF. So for our first outcome, we wanted to quantify the number of bronchioles per centimeter cubed of airway and compare that count across all three groups. We visually identified the bronchioles branching off of each small airway lumen on EBOCT cross-sectional images. Those bronchioles were then counted over 1 centimeter cubed of tissue in each volumetric imaging site, and then the bronchiole count was compared across IPF-affected, less affected, and control airways using Kruskal-Wallis tests and Dunn's tests for pairwise comparison. And then for the stereology outcome, again, we wanted to measure the area, perimeter, ferret diameter, roundness, circularity, and surface irregularity, and compare those metrics across all three groups. And we did that by doing some semi-automated segmentation of the airway lumen in each EBOCT cross-sectional image. And then these parameters were measured by an automated software on each cross-section and averaged over all cross-sectional images within each volumetric imaging site. Finally, those metrics were compared across all three groups using the same tests that I just mentioned. So this is our study population. It ended up having no significant demographic differences between the non-ILD control cohort and the IPF cohort. Importantly, we were able to match the control cohort smoking pack year history to that of the IPF cohort. The PFTs were also relatively matched. Only the DLCO in the IPF cohort was statistically significantly lower than that of the control cohort. And this does make sense because, after all, this is a group with IPF, so we would expect some restrictive defect to show up on the PFTs. So moving into our results for our first outcome, which was bronchiole count, when we looked at IPF subjects overall as compared with non-ILD control subjects, we compared the mean number of bronchioles and found that there is a statistically significant difference between them, where control subjects had almost twice the number of bronchioles than IPF subjects on average per centimeter cubed of tissue. We also wanted to break this down and look at the differences between IPF affected and less affected sites within the IPF cohort. There was no statistically significant difference between the IPF affected and less affected bronchiole count, but both IPF groups had statistically significantly reduced bronchiole count when compared with controls. So whether a site was affected or less affected, it still had a reduced bronchiole count. And if we think about this a little differently as percentage loss of bronchioles, overall in early IPF versus control subjects, we observed a 42% loss of bronchioles with almost 50% loss in affected sites and 33% loss in less affected sites. You can see this demonstrated in these airway renderings. And just to orient you first, we've shown the small airway lumen in red, and the bronchiolar branch points are coming off of it. Those are in blue. And let's focus now just on the blue bronchioles. And you can see the two IPF sites here have a visibly reduced number of bronchioles compared with the control here. And the IPF affected and less affected sites have a more similar number of bronchioles. And another thing I'll point out here is that when you look at the IPF versus control renderings, you can tell that bronchioles kind of get lost primarily in the distal end of the airway. We didn't evaluate that in this study, but it would be really interesting to see if that is also characteristic of IPF disease development. And we'll come back to looking at the lumen in the next slide. So the next outcome was to look at airway stereology metrics. The data here for each of the 6 lumen parameters, again, that was area, perimeter, ferrite diameter, circularity, roundness, and surface irregularity. That's all shown here, but I'll break it down also. So in general, for all of the stereology metrics we looked at, IPF affected sites were significantly larger and more distorted than IPF less affected and control sites. Interestingly, though, IPF less affected sites ended up being statistically indistinguishable from controls in every single parameter. So that was really surprising because we did expect that less affected sites would be more similar to affected sites in some parameters at least, but this indicates that the less affected sites actually had no notable architectural airway distortion when compared with the controls. So when we come back to take a look at those renderings again, we can visualize this. Again, the red is the airway lumen. And as you can see, the IPF less affected airway here has no significant lumen distortion as compared with the matched control. But the IPF affected airway clearly is significantly bigger, less round and circular, and more irregular compared to the other two. So taken together with the bronchiolar loss data, despite the fact that the IPF less affected sites showed no notable architectural distortion, they still have this 33% bronchular loss. And this led us to conclude that the bronchular loss may be a primary feature of early IPF pathogenesis rather than being a secondary feature due to architectural distortion. So there were a couple limitations to this study, one of them being the small cohort size. However, our cohort sizes are comparable to those that were used in the micro-CT studies. And then this study also has the added benefit of prospective demographic matching between the early IPF and control cohorts, including for smoking history. And that helped to provide further support for our findings being applicable to IPF specifically. We did also have a high number of imaging sites per patient, which were all heterogeneous due to the nature of the disease. So that resulted in a bigger sample size. And again, this is a similar methodology as what was used in the micro-CT studies. However, larger scale studies are still needed to further validate the bronchular loss and small airway abnormalities we found here. Another potential limitation could be that the control cohort did have a known single nodule, which was why they were undergoing the clinical bronchoscopy. However, our study protocol mandated that EBOCT imaging sites be selected away from the segment containing the lung nodule to ensure that there would be no nodule-related effects on the small airways that were evaluated. Additionally, the use of this patient population who was having lung tissue resected gave us the benefit of confirming the absence of any unexpected lung diseases on histology that were under the resolution of CT. So to conclude, EBOCT-based microscopic assessment of small airways in early IPF demonstrated significant bronchial loss, up to about 50% when compared with matched control subjects in vivo. The bronchular loss in IPF affected and less affected airways was comparable, but small airway lumen stereology was only significantly larger and more distorted in IPF affected airways, which tells us that bronchial loss might precede architectural fibrotic remodeling in early IPF. We were also able to control for smoking history, which allowed us to attribute these small airway abnormalities to IPF pathogenesis rather than to concomitant smoking-related small airways disease. And this data does support small airways disease as a pathologic feature of early IPF, extending the work done previously in micro-CT and end-stage IPF. So in light of these findings, we also did want to consider them in context with other known findings of small airway abnormalities in IPF. One of these being air trapping, which we know can be present in patients who have biopsy-proven UIP and clinically diagnosed IPF when followed over time. And the presence of air trapping might be another clue to some form of small airway abnormality being a part of IPF pathogenesis. Another finding related to small airway disease is the body of work identifying MUC5B promoter polymorphism as a genetic risk factor for IPF, which again links a possible small airway abnormality to IPF pathogenesis. All of this data also generates several additional questions, including how small airway pathology in IPF compares with that of other fibrotic ILDs. We also have an ongoing study currently in which we're collecting repeat longitudinal OCT data. And we have been able to reach the same airway locations during repeat imaging. So we would like to eventually evaluate how those small airways change as IPF progresses. We're also working on developing polarization-sensitive EBOCT, which detects birefringence from organized tissue like collagen and fibrosis, and thus allows for quantification of fibrosis. So that would be really interesting for assessment of the nature of remodeling around IPF small airways. And finally, we're also working on a study on clinically relevant interstitial lung abnormalities detected by EBOCT. So this would be another area to further assess small airways to see how early in the disease process those changes appear and whether they might be predictive of ILA progression to symptomatic pulmonary fibrosis. Thank you all so much for listening. Again, I'd like to thank my mentor, Dr. Lita Hurry, again for everything. And huge thank you to Dr. Shriyankar Nandi, Rebecca Raffaelli, Joe Lee, and Satomi Yamamoto for all their help with the project. And thank you again so much to the Clinical Problems Assembly and to all the panelists for listening and being here today. Happy to take any questions.
Thank you so much for that beautiful and insightful presentation, Sarita. As always, a very impressive presentation delivered in a crystal clear fashion. Thank you. We can now take questions from our audience, and please feel free to type your questions or raise your hand in the chat to ask directly. We'll start with our experts panel to get the ball rolling. I'll actually begin with a question that's been on my mind for a while. So I'll direct it to you, Sarita, and to you, Lita, as well. Given that you both showed significant bronchiolar loss in early IPF, even in regions that were considered less affected by fibrosis, which to me begins to suggest that small airways may play a more prominent role in early disease than we previously thought. Could this shift the focus of diagnostic guidelines that are currently centered on detecting subpleural fibrotic changes? Because that's how we define IPF practically. And how do you think this might begin to impact clinical practice, particularly in identifying IPF at an earlier stage, which is what you were alluding to during the course of the study? And I'll throw one last one in there as well. Might this begin to necessitate revisions to our current HRCT and PFT protocols in how we define the disease? I know it's a lot packed in there, but I want to see you unravel it, as I know you will very well nicely do.
Yeah, I'll start. I think yes, like especially with the HRCT guidelines, and like you said, subpleural predominance is part of the IPF or UIP criteria. And I think a lot of the time when we see, like I said, when we see air trapping on CT, we favor an indeterminate or inconsistent with UIP diagnosis over, a probable or definite UIP. And as we've shown here, that air trapping could be related to some small airways disease. And so I think that would benefit from revision. Lita, do you have anything else?
Yeah, I mean, I'd say it's worth considering. I mean, I think we need to take into context our study is small. The part that makes me think that this is real is that we're validating something that another independent, group of investigators has identified, and we're showing it in the same disease, but in an earlier stage. But our findings were very parallel to what they showed in end stage, just with us in early stage. So I think there's something there. It's just a question of how does that integrate into the way we think about the disease, the way we diagnose the disease. And I think Sarita was really, quite on the money there, that probably the first place is we know that there's this like adjunct where when you see, a mosaic attenuation in the background of an otherwise UIP pattern on CT, we're supposed to move away from a definite or probable and into the, oh, this is something else. We also know that when you look and dig into those, individuals, when you do have path and you follow them over time, it turns out they actually just do have UIP of IPF. Now, I think the question is how do you differentiate those that are UIP, IPF with air trapping versus those that have something else like HP or, with a UIP pattern? I don't know. I think we have some work to do there to help with CT guidelines to sort that out and see if there are more specific features that can help, tease that out more cleanly. And then also provide other methodologies that can help support the diagnosis of it being a pure UIP without other features that would indicate a secondary cause of the UIP versus idiopathic UIP of IPF. So if things weren't murky enough, I'm sorry, we just made them maybe slightly murkier.
No, that's fine. I think you start to suggest what leans towards a radical transformation of how we think about diagnosis and the disease. And I think that's really interesting to talk about. We'll take from Dr. Jenkins, and I see we have our panelists as well, Anna and Kerry, right after that. Ghislaine?
Yeah, hi, thanks. That was absolutely fascinating. I have a whole raft of questions, but I'll probably limit it to 2 or 3 to begin with. So the key question to my mind is this an intrinsic defect of small airways, or is this a consequence of the fibrosis? So are there cellular abnormalities within the small airways which are causing loss, or is it the fibroblast proliferation that's occurring in the parenchyma around the small airways that's just destroying the airways? And is there any way you could get, you've only got a small number of samples, so one of the benefits of that is you could get the lung tissue and do spatial transcriptomics on it and actually look at the cells. It wouldn't cost you an entire year's budget, but pretty close. But you could do it. Are you going to do it?
That's a really good question. And it definitely would be really interesting to look at that. Yeah, what do you think, Leda?
Yeah, I agree entirely, Gisli. I think that's right along our line of thinking as well. I think the data that we have is indicating, because I had expected when we went into the study, my hypothesis was that we would see small airway loss, but that it would be directly correlated with the amount of airway distortion. So I had thought that the airways being lost were because they got distorted, pissed off, and then obliterated. But then when we looked at the data and we saw that the less affected sites that didn't really have any distortion present, which also I think is important to note, that's not how we separated the groups, because unlike HRCT, we don't use traction or airway distortion to identify UIP. It's just honeycombing and destructive fibrosis. And so our less affected didn't have honeycombing, but there's no criteria that said they couldn't be distorted. So that just kind of fell out the way it fell out, just based on the sites themselves. But the fact that those airways are not architecturally distorted, but still have lost a third of their small airways is weird. And I don't know, it's totally surprised me. So yeah, I mean, I think that part of it will be looking at the spatial transcriptomics. And then the other thing I'm super interested in doing is in the longitudinal study where we're imaging patients at time point A and time point B, and in the sites where we're able to go back to the exact same site, seeing what happens to those airways over time. Like is an airway there at time point baseline and then it goes away later? Is there fibrotic remodeling? Is there something unique about the fibrosis around that airway? I don't know, but I'm really curious to try and tease it out.
What about other diseases where you know that small airway disease is important? So as a control.
Yeah, I think that would be the next step. We didn't do that as part of this study because in our initial cohort, we didn't have enough of each of the different subtypes to be able to really look at this. Even with an N of 12 of IPF patients, we were like, okay, that's probably plenty. But for the others, it wasn't quite enough. But now that we've accrued more data, once we've vetted those patients and we know with high certainty what their final diagnosis really is for sure, once we've done that part of the study, then I think the next step would be to go back and look at these small airway parameters and compare and contrast. And then also, as Sarita alluded to, I think the big question is does the distribution of small airway abnormalities matter? Is it that in UIP, you move from the very distal lung and you lose your small airways moving in? Whereas in an HP, maybe it's still distal, but more proximal and then moving out, which would be what I would hypothesize just based on where like the injury should inherently be? Or does it not matter at all? I mean, I think the bottom line is I don't know, but you're absolutely right. We'll need to answer those questions.
And one final question, if I may, it's a sort of pragmatic question for follow-up and replication studies. How scalable is this technique? Does it require a special scanner and a huge amount of your time, or can any radiologist or pathologist do it in any scanner?
Yeah, so I mean, the imaging technology itself, specific for lung, it is not commercially available, unfortunately. There are OCT systems that are commercially available for use in like cardiovascular and upper GI imaging are areas that are reasonably popular, and you can buy systems. The problem is that the catheters are different. So you need something that is unique for the lung to be able to fit in the working channel and also be robust enough to be able to like not break and in at the working port, et cetera. So we're working on trying to set up additional sites. We have a site at Beth Israel, so one of our sister hospitals here, and then we may be setting up some sites with some people who are on this call with us if the IRB ever like stops bothering us. So the idea would be then we would take this and validate it at other institutions. So there's that piece of it, that's the equipment. Now, the actual analysis, a lot of the work that Shrankar on the call has been doing is to create AI-based automatic segmentation so that in this study, it was semi-automated, but it was still a pain in the ass. I'm going to be completely honest with you. We had to do a lot of correction, et cetera. But with Shranker's methodology, ideally that will be removed so that then you just would be able to throw the data within their algorithm and it would just automatically segment the lumen for you, and you'd be able to get all of this information in a much more rapid time frame, which I think will then facilitate the wider scale validation a lot more readily.
Thank you.
Thank you.
Yeah, thank you, Lida. I think your data are very compelling, and it makes a really strong case for making both the AI algorithms and the OCT hardware resources widely available. So yeah, I'm behind this completely. Anna, and then Kerry, and then Barry.
Sure. So thank you, Sarita and Lida and whole team for doing this really amazing work. And I think it's really shifting how we think about the origins of IPF and how it may actually begin in the airways. And so my question actually follows and is similar to Gisli's question, but in IPF, and there's this beautiful single cell data out there showing that there's this idea of bronchialization of the alveoli and of the distal airways so that they look more like large airways. And so my question is, can you tell from any of your data, or have you correlated with the histopathology to see like what is actually happening to the airways? Are we just like obliterating the small airways? Are they just gone, or are they larger? And so because you're counting airways that are less than 2 millimeters, so are there more larger airways? Like, can you tell any of that? Like, where did those airways go?
Yeah, I think in terms of like the bronchular loss that we saw, I think especially because our data kind of points towards the fact that that might be the primary feature, and then architectural distortion kind of follows that. So we're thinking there might be, something else other than the distortion that's causing those bronchioles to get clipped off. As far as like airways getting bigger, we did find that the IPF, like the more affected airways, were larger and much more distorted. So that might be, what's going on there, and that might be what we're seeing. But that's a really good question that we haven't looked at here.
Yeah, and Anna, I can add on from a pathological perspective, like that single cell data is not surprising to me at all. Because when we look at the way that like IPF develops from a histologic perspective, it really is like it's an obliteration of what I'm going to call right now the alveolated parenchyma. But we also know that the alveolated parenchyma just isn't alveoli. There are pneumocyte-lined like airways that then lead into those alveolar sacs. And what happens is like as the disease progresses, those spaces get irritated and the pneumocyte-lined airways turn into respiratory epithelial-lined airways just due to the injury. Like anytime you injure any airway, no matter what you do to it, it goes, oh my God. And then it undergoes metaplasia because it needs to get a bit more robust to deal with the persistent injury. Same thing here. Even with the honeycombing, like you almost never run into honeycomb cysts that are like unlined or lined by pneumocytes. They're usually lined by respiratory epithelium. And I think one of the big questions in the field is, oh, well, if that's the case, does that mean that those airways get like clipped off and then turned into honeycombing? Or is it that alveolated or pneumocyte-lined spaces just get pinched and then distorted and then turned into honeycombing? I think the bottom line is we don't know. Like it's so hard to know that. If I had to guess, I'd say it's probably both things. But I think those are questions we really need to answer is sort of where is the injury happening and why is it happening? And is it really in the alveolus of the alveolar sac, or can it be all along the space of the airway that's pneumocyte lined down? Or does it maybe even involve the respiratory, epithelial lined airway? I think it's just a lot of I don't know, and we probably need to figure it out.
Thank you, Lida. It's always exciting to hear pathologists talk about these mechanisms. It takes us back to medical school. Carrie, your turn.
Yeah, thank you so much. This is so fascinating. And when I was first reading this and thinking about this, I was wondering about inhalational injury. And so from, a disease mechanism perspective, you match for smoking, but are there other parameters that could be leading? So whether it's aspiration or inhalational injury, like air pollution, occupational exposures, how those potentially over time could be damaging and leading to this bronchiolar loss, and whether that could be mitigated by the genetic status. If you could, obviously you would need larger patient populations to stratify by MUC5B and other genetic risk factors for the subsequent injury. But do you think that maybe this is informing that these are inhalational, occupational, environmental, inhaled injuries leading to this destruction, first of all, that then from an evolutionary perspective, then the rest of your lung is trying to compensate now for this bronchiolar loss and trying to say, okay, well, we're going to make the rest of the alveolus and the distal lung tissue try to compensate for this loss of airways in some sort of way. And do you think there's a way that you could move forward to characterize the exposure component of this that could be leading to that injury?
Yeah, I think that would be a really, really interesting thing to look at next. And yeah, I think the next step is looking at the small airways using OCT in all of these other ILDs and inhalational related, diseases. Yeah.
Yeah, and Carrie, I think you're right. We need much larger cohort sizes because, we're recruiting our patients from the Boston area. They're for the most part, like at least from that perspective, it's not like we're recruiting from like places where there's wildly varying pollution levels, et cetera, but still you just don't know in an individual person, like what garbage they're exposed to on a daily basis. And then I think you also raised an interesting point that I think about a lot is that when you think about like the airways of any ILD, but especially an IPF patient, like the stuff that's actually triggering injury for them, that's like the routine stuff, is all inhalational when you really think about it. It's smoking, it's probably pollution. I think if, there's data starting to support that, and I'm sure that will come out more and more and more. It's, viral infections that are introduced from an inhalational perspective. And so in some ways, although I was surprised by these results, when I really stopped and thought about it, I'm like, you know what, most of those particles, if it's really about something inciting injury, those particles are not going to get stuck at the alveolar sac. They're probably going to get stuck somewhere along the bronchial and bronchiolar tree and then create injury in that space. And it may be that, maybe we're splitting hairs a little bit. That, okay, is it the sac or the respiratory bronchial or the space in between? But it's still really interesting to think about that, like we've been so focused as a field on like that alveolar compartment of the pneumocyte, the capillary underneath and all of that space. And maybe that's still true. It's just an anatomic compartment that's just slightly proximal to that, where it's like those distal alveolar duct or terminal bronchioles that are leading in. And I think we're going to have to figure it out, but it's going to be tough. I imagine we're going to need large groups in order to sort out what people have been exposed to. One thing I think that could be interesting to do is like, and I don't know how widespread this is. There's a group at Yale. Oh, and I'm forgetting her name. I'll have to think of it, but they've got this really cool technology where like you wear like a thing on your wrist and it collects like all of the things you've been exposed to. And you can also put these little monitors in your house to like look for exposures. And they had initially developed it during COVID to look for viral exposures, but then they've now like extended the work to look for other exposures where like they're focused a little bit more on COPD and particulate matters related to that. But like I remember when I saw them present, the person who presented at One Bear Cage a couple of years ago, and I was like, oh my God, that would be amazing to like think about for IPF and all the other ILDs, hypersensitivity, like all these things. So I think that there's going to need to be some technological advancement so that we're not just relying on historical, like, do you have mold in your house, which the answer is almost always yes, but no one ever knows, right? That like they don't realize they have mold in their floorboards of their house that got flooded that one, it's so hard. But if you have something more objective and quantifiable that really is looking for mold spores, then you're able to tap into that in a way that I think will really change our field. And hopefully we'll get to that soon.
Can I just ask a quick follow-up, and sorry, but are you aware of other like of models of bronchiolar loss? Like, are there like a mouse model of bronchiolar loss? And I'm the last person to bring up a mouse.
No worries. Not that I know of, but I'm not probably the best person to ask. Although in some ways you wonder if the thing is bleo almost could be a model of bronchiolar loss because it's essentially a forced inhalational exposure to bleomycin. The problem is those poor little mice are really just getting organizing pneumonia, and they're so like robust that they're like, whatever, I don't care. And then they get over it because they're like mice who get over everything. So, I think that with those models, bronchiolar loss or not, we really have to figure out a way where we can tap into not just the exposure piece, but the underlying predisposition piece. And I think that's the part where in the preclinical models, we're struggling a bit, but making some good progress, I think.
Yeah, Lida, just to springboard of that real quick, given Kerry's comments on the exposome and inhalational injury and how it affects this whole process, and also in view of comments from Anna and Kristen in their editorial on the study, do you think that current diagnostic criteria and imaging approaches like HRCT should start to evolve to incorporate small area assessments much earlier in the diagnostic process? If you do, how do you think we can incorporate that into clinical workflows for IPF diagnosis?
Yeah, it's really tough, Deji, because like with HRCT, I think it's like, yes, you can see reflections of small airways disease, but it takes quite a lot of accumulated disease to actually be reflected. And we know that like run-of-the-mill people will just have a little bit of air trapping, and like what the source of that air trapping is or why there's variation just in the regular healthy population is like, I don't know. Is it just differences in underlying physiology? Is it differences in exposure? Do they maybe have some subtle small airway, something? Is it like me where I always get like post-viral like airway inflammation every time I get a virus versus a person next to me who maybe never gets that reaction? Like, I think there's that just like population based, like what are differences in sort of small airway physiology that's just run of the mill? And then on top of that, then there's when you do have a predisposition to any fibrotic lung disease, like what does that mean? And I think the other thing that, Serena and I have chatted quite a lot about is we wonder, like, is it all IPF patients who have small airway abnormalities? Is it a subset? Is it like a bell curve that some of them have none, some of them have some, and then some of them have a ton? And then maybe that's why things like, not everyone has MUC5B, polymorphisms, but then the ones that do, are they the ones that are more small airway dominant? So sorry to keep saying like, the bottom line is we don't know, but I think kind of the bottom line is that we don't know, and that this is good for us to remember that we don't know everything about IPF and that we do need to dig a little bit deeper at some of these pathophysiologic mechanisms, because even though we've been studying it for, 50 plus years, doesn't mean that we've fully studied it and completely understand it thoroughly.
But that's the very essence of research, right? We don't know. If we knew, we wouldn't
Don't
study.
Don't know. But I think sometimes we talk as though we do know, you know,
Yeah.
I think that's the tough part is we're like, oh no, this couldn't possibly be a UIP IPF patient because they have air trapping on their CT. And I think stuff like this starts to make us go, well, is that really true?
Yeah, so I was going to just ask Barry because I think he directs a PFT unit at Mass Gen or something like that. If we can't do it on HRCT, can we leverage PFTs, which we historically have used to assess small airway involvement as well? And maybe Barry can just chime in on this and then ask his question as well.
Yeah, I was actually going to chime in on this before my question too, because the other thing which is really interesting, I think, is that like we talk about gas trapping on HRCT scans like this is a really specific finding, and that like we don't even really have much data to support that what we're talking about as gas trapping really is gas trapping or small airways disease. So, we're really looking at mosaic attenuation that gets accentuated on exhalation, right? And so and we assume that's gas trapping, but I don't know that we have great data for that. So, I think it's really hard to investigate the small airways, and I think obviously like things like FEF 2575 have been debated for decades as to whether that's really a useful measure or not. I think perhaps forced oscillometry might be a way that we can really start to look at the small airways in diseases like IPF. I just think we're not there yet. And I think that I would sort of echo the comments that Deji and you and others have made. We don't know that much about what really gas trapping on CT scan means. And it's just a very non-specific finding, I think. So but my question was really, I think, kind of in a similar vein to some of the others. I think Sarita, this is really, really phenomenal work, and I'm a fan of it. But and I think the thing I find really interesting is the potential connection with the MUC5B promoter polymorphism, right? Because in that scenario, there has been a link to small airways disease in IPF, and I wonder if we may see some heterogeneity in the small airway abnormalities, and that may be a potential link to some molecular heterogeneity in IPF pathogenesis, right? If you can have enough patient samples where you have genetic data, maybe you start to see some connection between patients with MUC5B promoting polymorphism, the risk polymorphism, have maybe a greater degree of these small airway abnormalities, and maybe in those patients, the disease is really originating in the small airways. So I guess more the question is, can we perhaps use this to start to explore some of the maybe different molecular pathways that get to ultimately what we call IPF, understanding that that's probably a heterogeneous disease.
Yeah, absolutely. I think, finding the relationships that these small airway abnormalities have with the MUC5B polymorphism and, air trapping like we were talking about, that's definitely a major next step that we would want to see, like if these things have any associations, if this small airways abnormality population is, sort of a subtype of IPF, does that relate to these other subtypes that might be there that have the increased MUC5B expression? And yeah, I think it would be really interesting to look into that next. Yeah.
Great. Amanda?
Thanks, and thanks for the wonderful presentation. I guess maybe this is a little bit early to ask, but should we be rethinking inhaled therapies in IPF? Do you see any role that you could, structurally phenotype patients? And what are your thoughts on kind of therapeutic implications of this work?
That's a really good question. And I think it plays into, what Lita was saying also about how we just don't know, I'm sorry to say. Because it's even I think it does tie into the diagnostic question of whether we should modify our criteria. Again, this might just be a subtype of the population that has these small airway abnormalities. So I think it really would depend, how many of these patients actually have these, changes. But yeah. Does anyone else have thoughts?
It's an excellent question. And in fact, a lot of people ask me, I was just at the IPF summit and all the inhaled therapy peeps were like, oh my gosh, does this mean the inhaled therapies are going to be better? And I think the bottom line is we don't know. But at the same time, I feel like there's two pieces to that question. One is, we know that the epithelial injury is incredibly important. And when you're giving drugs systemically, you have to get through the vasculature and up to the epithelium and to the fibrotic regions in order to have impact. So there's that traversity. And if you can deploy these drugs in a way that A, have less systemic side effects, and B, are more targeted to the epithelium, and if it turns out that it is sort of this not alveolar space, but the step before that really you want to hit in order to treat, then maybe that would be an argument towards inhaled therapies. Now, one of the things I've been thinking about, which to be honest with you, it's just a thought in my head, but I'll share it with this group, is you also wonder that when you are deploying an inhaled therapy, you're exposing a patient to an inhaled thing. And I think it becomes really important to ensure that nothing else within that inhaled compartment, whatever you're using to sort of solubilize and then distribute the drug, is not in any way unintentionally also creating some sort of form of micro injury as well, which you're not going to get with a systemic therapy because you're not inhaling it. So I think that, as the studies roll out, we'll see, what efficacies there are and, what sort of, other potential, adverse events may or may not pop up. But I think it would be interesting to know that. And then I think it comes back also to the question of if it turns out it's more about, it's like not everyone is the same, which I think we all probably know is true in IPF. Not every IPF patient is all the same. But if it turns out some of them are more airway predominant disease and some of them are not airway predominant disease, does that then help us to determine whether someone may be more sensitive and responsive to an inhaled therapy versus a systemic therapy? I don't know. I mean, that would be ideal if we would ever get there. And, I think we can all keep working towards it and hope and wish that at some point we become so personalized that we're able to phenotype a patient and say, this patient really fits into this box and therefore they should be treated in this way with these specific targets versus this other patient should take a different approach, either in delivery of drug or type of drug you're using, sort of like what, the lung cancer field has done. And I think from my perspective, I'm hopeful. Having watched that lung cancer field evolve over the last 20 years from no therapies to now a therapy for every single subtype of lung cancer there is, I'm really got my fingers and toes crossed that with IPF we'll get there too.
Yeah, I was going to just ask Anna and Christine, based on the editorial on this paper, there's been a lot of allusion to MUC5B today in this talk. And we're witnessing the beginning of an era of, genotype-specific precision medicine, particularly with Precision's IPF, the clinical trial in progress. Do you both think that genotype-driven approaches could start to redefine how we treat IPF patients? Those with specific genetic predispositions are the ones I'm referring to. In the light of the study from Lida and Sarita, what are your thoughts about this?
I'll let Kristen start, and maybe I can add.
Sure. Yeah, no, I think that that's a great question and a great point. And that's my hope. And I'm hoping that we can use OCT to help look more into that with MUC5B versus people who have the risk variant and people who don't in the future as a future avenue. But I think we're already starting to look into some of that with the Precision trial is trying to do some precision-based approaches. And I think that's a really interesting avenue. And I'm hopeful that we'll reach a point where we are able to have treatments based on patients' specific risk factors.
Yeah, I'll just add briefly that yes, I think we are going to move into a precision-based era, whether it's going to be based on the MUC5B genotype. I think we need to better understand what it does exactly. In that same, when we wrote our editorial, we also commented on another paper in the same journal that also focused on the small airways and was from David Schwartz, and it's spatial transcriptomics on the small airways. And they stratified based on MUC5B status and really showed some exciting results, kind of looking at differentiation of airway cells and how it's different in individuals with IPF and those without IPF, but with the MUC5B variant. But we really need more data like that. And I love Gisli's original question about can we do spatial transcriptomics in these patients? Can we collect and really start looking at the biology to better understand what MUC5B does, how it impacts the airways, and is it a potential therapeutic target or a biomarker that can indicate patients that have differential response to therapy?
Thank you so much, Anna and Christine. So we are almost at the top of the hour. I'm going to take a few moments to just wrap things up real quick. I would say, given this remarkable publication that we just heard, we expect to see a lot of progress along these lines in ILD over the next few years. I want to thank Ms. Berigay and Dr. Hariri for putting together such a fantastic presentation. I was just in awe as I listened to them speak. And special thanks to my wonderful panelists for their additional insights, questions, and just really excellent comments. Once again, we're very grateful to Samantha Carpin for facilitating this Journal Club webinar. And I also appreciate, Andrew Gengemi for helping to coordinate questions on the chat, and my other Journal Club co-editors and other members of the Clinical Problem Assembly who helped to put all this through. Finally, thank you to the audience, you wonderful guys, for your participation today, for listening to us at this wonderful, beautiful October morning. I wish you a beautiful rest of your day and happy fall. Bye.
Thank you so much.